the side effects of this drug are different than any. Find me another drug in oncology where we're worried about wound healing. That's different.
Especially with patients who are newly diagnosed and they have to have surgery. And then if this is going to be their first line of treatment, to have to wait for 28 days.
Oh, yeah.
Oh, my, the stress that, this probably puts on them.
Oh, yeah, it's tough. As infusioners, the last thing I'm generally thinking about is thrombosis and VTE. It's not on my top 10 assessment list. And yet for this drug, we have to pull that out of the back of our brains and remember that.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. All nurses know how difficult drug names can be to pronounce, and podcast hosts are not immune. In this episode, I occasionally refer to the drug we are discussing as bevacizumab, but it should be bevacizumab. All the crucial information in this conversation still applies, and we've linked a resource in the episode notes to explain the complexity of drug names for anyone else who gets mixed up. Thank you for your continued support. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member Seth Eisenberg, Professional Practice Coordinator of Infusion Services at Seattle Cancer Care Alliance in Washington, and member of the Puget Sound ONS Chapter, to discuss how to safely administer bevacizumab. This episode is part of an ongoing series about outpatient oncology drug infusion. The others are linked in the episode notes. Thanks for joining me today, Seth.
Oh, my pleasure. Thanks for having me on again.
So to start us off, how does bevacizumab work to stop the growth of cancer cells?
Well, I think it's important for us to first take a look at sort of how it functions, looking at what's happening with tumor growth. This is a different type of antibodies. It's a very unique drug, and it's a humanized monoclonal, and we know it's humanized by looking at that ZU in the middle syllable there. So it's a humanized, but it's a vascular endothelial growth factor inhibitor. And this is important because we know that many tumors overexpress pro-angiogenic growth factors in an effort to increase blood flow, keep the tumor alive, and to facilitate metastasis. So this drug blocks the VEGF from receptors, and it stops what I would say is new construction of blood vessels. And by affecting that tumor vasculature, it does kind of two important things. One is decreases the ability to feed the tumor or start to starve the tumor here. And the second thing, which is actually really interesting, is that it reduces interstitial pressure from these rogue blood vessels that the tumor tries to make, and allows chemotherapy to get to and find the tumor better. So unlike other monoclonals where we're actually targeting a specific CD, a cluster differentiation, we've got drugs that target CD20 and CD52, et cetera. What this does is it slows down or prevents the ability of the tumor to spread. And that's why it's generally used in combination with chemotherapy. So it has a different purpose and a very different mechanism of action.
Well, thank you. I think it's good to understand that, like you said, and understand the actual process of how it works. And the fact that it's used in combination because of that. So what diagnosis, cancerous and non-cancerous, is this drug used to treat?
Well, this drug it's old. Not as old as rituximab, but it's pretty old. It was first approved in 2004, I believe, for metastatic colorectal cancer. Since then, it's been approved for several other cancers, including lung cancer, renal, metastatic or unresectable hepatocellular carcinoma, cervical, then ovarian in 2014, and then glioblastoma in 2009. Those last two have particular significance for me on a personal level with this drug because if I can diverge for a second here, my sister passed away from ovarian, and she was trying to get into one of those trials back in 2013 and didn't qualify for it at that time. And my wife passed away from glioblastoma before this was in trials for that. So certainly this drug has been trialed on a lot of types of tumors and has a lot of use. It's also got one off-label use here, which is for age-related macular degeneration. So it's used for ophthalmic issues as well, off-label.
Well, thank you for that. And I'm sorry to hear about your family. And, as oncology nurses, as we are in practice and, we see all of these new therapies come to fruition while we watch them in trials and then see how they're brought into actual standard treatment options for people, it definitely pulls at our heartstrings a lot of times, because we all have those people that are special to us that we know these treatments probably would have worked on, or at least extended their time. I mean, it's that bittersweetness, like we're so excited to see the progress that's being made, but, just knowing those kinds of things. So thank you for sharing that with us.
Yeah, no problem. I always like to keep in mind that all of us have been touched by somebody with cancer. So it can be personal. So
absolutely. So can you walk me through the administration process for bevacizumab?
So this drug is given between 5 and 15 milligrams per kilogram. That depends on the diagnosis and the regimen that's being given with and the frequency of that regimen. And I start off with this because this milligram per kilogram is different than what we're used to with other drugs. Chemotherapy, we've all gotten pretty used to milligrams per meter squared, except for maybe carboplatin, which has an AUC, or for the monoclonals, there are several now that have flat dosing. So this is different in that it's milligrams per kilogram. When I remember reading, they based that on the best biologic dose rather than maximum tolerated dose, which is what we do with chemo. No premedication is required for this drug because reactions are really rare, which is really nice to know that. But the key thing here is a really good, thorough assessment that has to be done with the patient, particularly to evaluate for the presence of hypertension or prior history of hypertension. We want to make sure that we've talked to the patient about any recent bleeding or past surgery or looking for positive proteinuria. There's also a black box warning for this drug that discusses GI perforations, wound healing complications, and hemorrhage. And these are big things that we'll talk about a little more later. But so I think in terms of administration goes, you're going to want to make sure that we've looked at these things and discussed these things with the patient first. We're all pretty much used to looking at our parameters for our counts and looking what our A&C is and maybe our renal function, but these are different. They're different than usual and kind of goes along with this being a different kind of drug. First dose is given over 90 minutes. Then 60 minutes for the second dose and 30 minutes for subsequent doses, which is it's actually a very unique way of titrating. Essentially, it's not the same titration that we would use with drugs such as rituximab, but it is done that way. And I actually like this way of doing it because number one, you sort of give it slowly at first, and then the patients will know that when they come back for subsequent doses, their visits will be shorter. And the bottom line is patients don't want to spend any more time in the infusion department than they have to. So that's a good thing on this.
You're right about that. The shorter amount of time they have to spend in there, the better. So that is really a great thing about this drug and the administration of it. So you talked about some of the things that we need to watch out for briefly. Are there any patient populations that should avoid this treatment?
Essentially, any patient that's actively bleeding, so if somebody comes in and they've got hemoptysis or vaginal bleeding or something else going on, there should be a discussion with the physician because it should be generally avoided with that. Any patient that isn't at least 28 days post-surgical procedure, and since this is used for colorectal, there's almost always going to be some surgery involved. So it's got to be 28 days, and doses should be held for 28 days afterwards, so before and after kind of a thing with this drug. Patients who are pregnant, plan to become pregnant. And we could say it's true for almost all drugs, but because this is a hazardous drug as a monoclonal, we want to make sure that we've sort of screened adequately for that. And a discussion should occur, I think, with the medical provider for any patient that's experiencing hypertension, because they may need to either hold the dose or completely discontinue it. If the hypertension's bad enough, I've seen patients that have just been taken off the drug, period, because the hypertension can be a huge deal with this drug. So, and again, that's unusual. We don't have that with a lot of other drugs.
Yeah, those are good things to know. And like you mentioned with the 28 days for patients who have had surgery, I'm sure, especially with patients who are, newly diagnosed and they have to have surgery. And then if this is going to be their first line of treatment, to have to wait for 28 days.
Oh, yeah.
Oh my, the stress that this probably puts on them.
Oh, yeah, it's tough.
Right, exactly. And I think that, so it's so important for us as nurses to be able to educate those patients and understand that and really get across why that is.
Yeah, the patient education of this drug is so important, maybe more so than a lot of the other monoclonals. And depending upon how the organization is set up, this education could occur with a nurse, like a clinical nurse coordinator, who isn't going to be infusing the drug, but will be meeting with the patient beforehand. And so I think it's important that those nurses in that role understand the uniqueness. Again, I keep saying unique, but it's true, the uniqueness of this drug.
Yeah, you're right. So what are some of the common adverse events, or you did mention that there really aren't infusion reactions with it, but how can nurses mitigate or manage the adverse events that go along with this treatment?
Part of it is, like I said, there's not many reactions during the drug, but the ones that we're concerned about are this impaired wound healing. This is so important, again, for reinforcement so that patients don't go out and have a procedure while they're on this drug. As patients, especially patients in older demographics, tend to have multiple physicians caring for multiple aspects of their care. And sometimes there's a disjoint in the fact that one physician doesn't know what's happening. So the patient is sort of the center of this and needs to understand that if one of their other physicians in a specialty wants to do a procedure, that's something they need to be aware of being on this drug. Proteinuria thing is important. Patients need to get their urine checked for that. The hypertension, and just going back to that again here for a second, is depending on the age and the diagnosis, it ranges between 16 and 42%, and that's pretty high. And it's really high with patients with colorectal cancer that are greater than age 65. That's where it really is. And the other thing is that there is an increased risk of patients having thromboses or VTEs with this drug. And off the top of my head, I can't think of any other drug that really carries that kind of risk for thrombosis. And I'll be very honest with you, as an infusion nurse, the last thing I'm generally thinking about is thrombosis and VTE. It's not on my top 10 assessment list. And yet for this drug, we have to pull that out of the back of our brains and remember that for this drug. And we have to remember all those things that we learned probably in just basic med-surg about signs and symptoms of embolisms. Now, while we may see that with certain patient groups, like myeloma tends to see that on drugs like the IMIDs, we don't normally manage those in oncology. But here's a drug that causes that. And so that becomes something we really have to be tuned to, we have to educate to, and we have to assess for that.
Yeah, I think we are definitely trained, and just even that memory, kind of the muscle memory, but brain memory of the side effects that we need to watch for with our patients. And, when they're getting the treatments that are what we consider common or that we use a lot. But when you have things come along like the monoclonals and other things that have kind of these off of our norm of what we would look for, it's so important for us to understand and know what those are, and know, what kind of things we need to assess for. And also, sometimes, are there certain lab tests that we need to get, or, different things like that.
Yeah, and I would even add to that if you're somebody as a nurse who works in triage, for example, and I do weekend phone triage as part of my job as well, and a patient calls in with signs and symptoms that turn out that they sounding like they've got a clot somewhere, and I look up their chart, what are they getting, and I see this drug, I need to be able to put two and two together. because we got to connect those dots. And I guess why it's really important just to understand some of these unusual side effects of these drugs, even when you're not the nurse giving these drugs.
That's a really good point for, if we have anybody that's listening to our podcast who might be in a position like you're talking about it in triage, to be able to, how important it is to know that.
Yeah, absolutely.
We often get questions from our ONS communities, and we would pull a few of them to ask you today. So there was a communities thread that discussed the importance of waiting to administer bevacizumab for patients who receive a new port. So what is the recommended wait time, and what are the increased risks of administering bevacizumab near a port placement that hasn't fully healed yet?
Yeah, this is a biggie, because again, once a patient gets their port, they want to get started with their treatment. They don't want to wait for things. So this is a tough one. But again, you can have total wound separation from a port placement, and I've actually seen one. I've actually seen a patient who was a number of years ago, was probably right after the drug was approved, whose port pocket completely opened up and separated. And they traced it back to this drug that the patient had received. And I don't recall if it had been 28 days or been less than 28 days. I don't remember the number, but I remember vividly what the wound looked like and how long it took to heal afterwards. And, when you're inhibiting the body's ability to grow normal blood vessels, which is what the drug is also doing, then your wound is not going to heal up. And the last thing we want to do is number one, delay treatment, but we also don't want the patient to have an infection from a port pocket wound. And so the 28 days is a minimum on this. And if you've never seen what one of these look like, it's pretty scary. It's the reason why I've never gone into surgical oncology. Yeah, so
you're right. And honestly, when you see something like that, you're never going to forget it. And to have those experiences or, those stories to be able to tell and explain to other nurses and patients, because again, that's another time when patients are going to get, really anxious that they have to wait for that long.
Oh yeah, and I don't blame them. I mean, you want to get a jump on this cancer, and getting your port placed is kind of like the green light in theory to start your FOLFOX or FOLFIRIs or whatever you're doing, and that's tough to wait.
So we have another question that came through the communities. This one was discussing what vital signs to assess and monitor during the bevacizumab infusions. What are best evidence-based practices for monitoring patients during this treatment?
So there's always a variety of opinions on this when it comes to monitoring, but at a bare minimum, you obviously want to do your vital signs pre, and you definitely want to make sure that you've got an accurate baseline blood pressure, because again, this is looking for that hypertension here. So pre and then post. Now, some places actually do it somewhere in the middle, but you got a 30-minute infusion. It's pretty tough to do something 15 minutes later, and you won't always see hypertension during it, but you can see it afterwards. And I have actually seen a patient just a few months ago, in fact, whose post infusion, they were like 210 over like 130, 120. And I mean, it was lights and sirens, with the physician, that this was a big deal of having to deal with. We don't keep these patients for post observation because we don't anticipate reactions. So it's not like we're going to keep them for 2 hours to check their vital signs later. And this is kind of a challenge, because you won't necessarily see the blood pressure go up during the infusion, but it could happen 6-8 hours later. So it comes back to re-educating the patient and knowing that this is a potential problem.
Again, another excellent example of why, we do need to know what things to watch for and monitor our patients for when they're getting treatment. We've talked about how we administer this and how we monitor patients and things like that. And you've really pulled out a lot of, good differences that this specific drug has from other treatments. Are there any additional training or education things that you think nurses need to administer bevacizumab?
Well, I think I would add to that we really want to make sure that people treat it like chemotherapy when it comes to safe handling. The drug can cause a reproductive toxicities, and we want to make sure that people are safe in terms of how they administer, how they handle the drug. There's a whole discussion on what the risks are in terms of for the administrating nurse, but in terms of it being classified as hazardous, it is. So we need to treat it that way as well, which is, again, different than some of the other monoclonals.
Good to know. So we've gone over a lot of things, and I appreciate your expertise on this and just, being able to give us the information on this treatment. There are a few questions that we ask every guest that comes on, and I just want to finish up with those. So first of all, what are some common misconceptions about bevacizumab?
Well, the first one I would say is that people often think about monoclonal antibodies and think of infusion reactions. And it's true for a lot of them. There's probably more that do react than don't react. So I think that's one of the things that's a misconception. There's a caveat there, a little asterisk. Any patient can react to any drug at any time, of course. So we're talking about, statistically speaking, this is not a drug where we're majorly concerned about reactions. But I don't want to make a blanket statement that you can't react to this drug, but it's not that. And the side effects of this drug are different than any. Find me another drug in oncology where we're worried about wound healing. That's different. So I think we just need to remember this is not the same as other monoclonals that we give all the time.
What's something about bevacizumab that's not often discussed, but you wish people knew more about?
Well, I kind of touched on a little bit of this earlier, but I'll kind of reiterate and go a little bit deeper on it. But for patients with colorectal cancer or non-small cell lung cancer, their incidence of developing a grade 3 or grade 4 VTE is higher than anyone else. And something else that's interesting is that once a patient's had a VTE, the risk of developing a subsequent one while they're on treatment is 7 times greater than the average patient. So it's a 7-fold increase. So this is like flashing lights. We really need to be on top of this because that's that's a big difference in that. And again, I'm not going to go back and talk about the whole that we don't assess for this normally, but we just need to be really aware of that and driving home that point because it's unusual and different.
And what patient and caregiver education should oncology nurses provide?
This is a great question because it kind of ties together pretty much everything we've been talking about so far. So, I'll group patient caregiver into the same bucket because I think they all need to hear the same information, be consistent. So we normally think about bleeding concerns with patients being associated with thrombocytopenia. We've all given the lectures to patients about what they should and shouldn't do when their counts are low, when they're natoring, et cetera, and it's low platelet count. Aside from obviously sepsis and DIC, which is a whole separate discussion. These patients need to know that the drug can cause severe hemorrhage without having low platelets. And that's a key point there that we don't always emphasize because we associate hemorrhage with having a low count. The patient would say to me, yeah, but my platelets are great. They're 80,000, 100,000, whatever it is. That doesn't matter. They can still be at risk for that. The other thing I would go back and talk about hypertension being very insidious or silent, so it can creep up, and the patient may not even know they've got it. There are some signs and symptoms, though, that are worth reviewing with patients just in case they do have it. So, like associated with like headache, is one. Nosebleeds is another. Nosebleeds is kind of a double whammy because it could be the bleeding part of the drug or the hypertension part or both going on at the same time. Any kind of visual changes is a thing they need to tell the patients to call us if they have that. And again, hematuria. So these are things that, we talk about hematuria with certain other drugs because they can cause cystitis and things like that, but we don't talk about it with every drug. So there's just some weird combinations of things that this drug causes that need to be included in our patient education. And probably the last thing that I would mention, and I would be cautious about how we describe this because it can it can be a little frightening, but bowel perforation with patients with a history of obstruction or diverticulitis is a big concern as well. And again, that's we don't want to scare patients with this, but in reading a patient's H&P, if we notice that they have a history of that, it's appropriate to bring that up just to make sure that they understand that any kind of abdominal discomfort that comes up sort of out of nowhere could be an emergency, and not just to dismiss it as a little indigestion from something I ate, or this is still left over from when I had surgery or something like that. I mean, these are obviously emergent, important issues that the healthcare team needs to be aware of, and they need to call.
Great, thank you. Can you let us know where is a good place for resources for patients and providers who want to learn more about bevacizumab?
Well, starting off with providers, I think for us as nurses, I mean, everyone's got their favorite places to go. My recommendations are, number one, the ONS chemotherapy and immunotherapy guidelines have a lot of information. It's a great place to go. There are some great books out there. I'm not going to plug all of them, but they're great books. And one place that we tend to forget about is the drug's website. The manufacturers, it's interesting what the manufacturers have done since the use of the web has become so prevalent and commonplace, and even grandma and grandpa are on the web right now. I think the websites are great. And the nice thing about the websites, and this is true for pretty much all of them, is that they divide it up into, if you're a patient, click here. And I like the websites because they actually spend some high dollars in giving wonderful graphics and animation on how a drug works. And it talks about side effects. It also talks about patient reimbursement possibilities and things like that. So it's a great resource for patients. But there's also usually another link on these websites for providers, for healthcare providers. And it gets into the more technical aspects of it. It gives you information. It gives you study data, which is always fascinating to read. Plus, it gives you an up-to-date link to the current package insert, which is kind of the FDA Bible of what is published based on the pivotal studies that got the drug approved. So I happen to like those because if there's changes in the drug due to new toxicities, post-marketing toxicities, it's going to be there. The textbooks won't always have those because books tend to get out of date. The websites get updated. So I'm a big proponent of these websites, which is not to say I tell patients just get on Google and do a complete Google search for everything, because there can be a lot of misinformation out there, but I will direct them to the manufacturer's website. So that's kind of my favorite places to go.
Seth, thank you so much for joining me today and for all the information that you provided. I think you've really given some great pearls for practitioners who are working with patients who are receiving this treatment, and things that we really need to remember about not only this treatment, but anytime we're administering, anti-cancer treatment to a patient, just that we've got to be so aware of everything about those drugs. And there might be something that is out of the ordinary that we're not used to, that we really need to remember about them. So I appreciate you joining me. And do you have any final comments?
The only thing I would add is that it's an interesting thing that depending upon the setting you're working in, there may be certain groups of drugs you give all the time. And then there are drugs you may give less frequently. I think what we talked about here today is a good reason for why it's a really smart idea to review drugs you haven't given in a while, because you may come up with these unusual things that you'd forgotten about in the past. So yeah, I would add that. In addition to just thank you once again for having me on. It's always fun to talk about these drugs.
Thanks so much.
You are so welcome. Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.